Anesthesia for squint, these are all the type. This is the normal way. You can see the pupil will be in mid position in normal eyes, whereas the pupil moves inwards or outwards, depending on. So the technical term is esotropia and exotropia. If it comes towards the medial canthus, it is called esotropia. If it goes away from the goes to the lateral canthus, it is called the exotropia. If it goes down, it is called hypotropia, and if it goes up, it is called hypertropia. And so these are all the patients. This patient will have a normal vision. This may will have a binocular squint. This is a divergent strabismus. This is a monocular squint. These are all the various types of vision that will happen. So this is the typical case scenario what we have done. We artificially did it like this for the entire movie. Look at his effort. And this is the isolated or secondary to muscular disorder, or may be associated with if it is associated with muscular disorder, the chance of malignant hyperthermia is very, very important. So you must ask this to history whether there is any associated muscular disorder or any family history of malignant hyperthermia. The indications for surgery, it may be cosmetic, or it may be to correct squint cosmetically only, or head position, or mechanical appearance to improve, and also the vision acuity. And sometimes it may be associated with serious anomalies like congenital heart disease, cardiomyopathy also may be there. So they also should be ruled out. And CNS anomalies which may be there are cerebral palsy, myelomeningocele, hydrocephalus, craniofacial syndrome, seizure disorders. So please ask history about both the things, serious and CNS probably. This is a squint, hypotrophic squint. Eyeball is looking down, and this is a child with a. This is a cerebral palsy child. You can see the child is not able to lift the hand, and somebody is holding it. And this is a syndrome with. So sometimes they may ask you about the applied anatomy of the orbit, what are all the structures that are going through. And the problems in strabismus surgery are increased risk of nausea, vomiting, and oculocardiac reflex. Of course, the other ocular reflex are oculorespiratory and oculoemetic, but these two you have to definitely remember: incidence of post-op nausea and vomiting and oculocardiac reflex. And adults, we can do it under local anesthesia, peribulbar block itself. But for children, it is not possible because they may not cooperate. So the pathway for oculocardiac reflex will be definitely asked. So it is a trigeminovagal reflex. So what are the factors which trigger that? Or the traction on the extraocular muscle, or pressure on the orbit, or ocular trauma, or increased intraorbital pressure from an injection or hematoma. And the response is usually disappears with repeated stimuli. So this is called the vagal escape or OCR fatigue. So initially it may go down with the bradycardia, but repeated stimuli gradually return the heart rate to normal. So that's called the vagal escape or OCR fatigue. So how to manage that? If the heart rate goes down, you must stop the surgery for a few minutes and then try again. If it is not associated with very severe bradycardia, you can again proceed. In cases where it not responding, goes to severe bradycardia, you have to inject atropine. So many people keep atropine readily loaded and use it in case of necessity, and make sure that the depth of anesthesia is normal and there is no hypercardia, and surgical manipulation is gentle. These are the three things which can prevent further recurrence of this particular problem. And this is the pathway: the traction on the muscle, the long and short ciliary nerves are the ones which carry that sensation to the Gazinian ganglion and the motor nucleus. So there is a connection between this motor nucleus of the fifth nerve to the vagus nerve. So it affects the efferent pathway is the vagal nerve going to the heart. Afferent pathway is the long and short ciliary nerve. This is the pathway for the oculoemetic reflex. So coming from extraocular muscle, it stimulates the vestibular nucleus, and the medial testicles to the reticular formation, and because vomiting center is in the close proximity, that is stimulated, producing nausea and vomiting. So this pathway you can see, this is how it is coming. Medial longitudinal fasciculus coming to the motor nucleus, reticular formation, from where the vomiting center is stimulated. And oculoemetic, these are all the reflexes. Strabismus surgery must the most common. It can be done under total intravenous anesthesia also. There's centers doing large volumes of strabismus. They use TIVA for reducing the incidence of post-op nausea vomiting, because usage of volatile agents may also aggravate the problem of that. And intraoperative OVR should be, so you can prefer to use this sort of armored LMA, which is also called flexible LMA, or you can use a cuffed oral ray tube. This post-deption test is a test done by the surgeon intraoperatively during the distinction any restriction movement due to mechanical causes and from increased muscle tone. So how can the anesthetist help? We can use neuromuscular blocking drugs to produce complete muscle relaxation. This will paralyze and relax the muscle with increased tone, but cannot relax the muscle restricted by mechanical causes like fibrosis. So what is best sign? Sometimes the eyeballs remain rolled up, is known as, actually this picture does not show the eyeball completely, but this is how you cannot see any part of the cornea here. You can see only the sclera, so the eyeball has gone up. That is how it looks when you put the speculum and open the eye. To avoid this problem, you must have adequate depth of anesthesia and maintain neutral position achieved by inhalation agents in adequate concentration or propofol infusion. So just to give you an idea, what is being done is they can resect a part of the muscle and then suture it, or remove the attachment and push it backwards. Both the things are done to position the so muscle can be brought forward in one place, opposite muscle is moved backward. That is what is being done. That is the principle of squint surgery. Okay? So that is